immediate removal and replacement. I don't know if anyone disagrees. So that goes to my second question. And also, in terms of retroverted uteruses, just as a key point, when you're putting it in, you might want to grab the posterior lip of the cervix instead of the anterior lip to straighten out the uterus. And in my group, because we have access, we had a few perforations. We are no longer putting IUDs in without ultrasound guidance.
And then I think for your other question, because the Paragard IUD works by creating an inflammatory environment in the uterus, there's a greater incidences of Paragards getting stuck or being moved or pieces breaking off. So I think that's a big difference in removing a Paragard versus a Mirena. We just have to be more careful when removing Paragards under ultrasound if we think that they're malpositioned or embedded.
And what do you mean by they felt the IUD in hysteroscopy? They felt the IUD but couldn't see the IUD.
Yeah, so under ultrasound guidance and using alligator forceps, that area of echogenicity was felt as a hard area inside the uterus, but then when hysteroscopy was performed, the IUD fragment was not seen. So likely there was some scar tissue or endometrium or something preventing us from seeing the piece.
Did anyone try a loop excision? Was there a thought to do that? You could feel it with a loop. If you could feel it with an alligator, you could put a loop on and feel it through that and then possibly excise it that way.
That was not done because I think it was discussed with the patient that we would try with ultrasound, with forceps, with hysteroscopy, and if we were unable to retrieve the IUD, the patient just wanted a hysterectomy.
Okay, just so you should know also about the alligator forceps idea, if you already have an IUD that's broken apart, I don't know that blind grabbing is the best idea. You might just want to go straight to the hysteroscope next time, because you'll just break it apart more. Right? You already have a fractured IUD. You want to be very delicate with it, more delicate than just yanking blindly.
I see that Dr. Montero has his hand up.
Hi, Raj. Just a quick question. So you said that you referred her to MIGS. Why did you refer her to MIGS and not to a generalist?
She definitely could have been referred to a generalist, but I don't really have a good reason. She definitely could have been referred to a generalist or to a minimally invasive surgeon.
Okay. All right. I wasn't sure if there was something more that I missed, like with her history or anything. Okay. All right. Thanks.
No.
I see that Dr. Bayat has her hand up.
Hi, good morning. Thank you for that presentation. At the time when the patient presented to the emergency room, was there any counseling about the risk of fragmentation with removal? And was there any assessment made as to whether or not the patient desired future fertility before the removal attempt was made, and how fragmented pieces of a retained Paragard might impact her future pregnancy planning? And were the images themselves reviewed by the team? And if they were, what was the reasoning as to why they did not want to use ultrasound guidance for the attempted removal in the ED?
So the images were reviewed by the residents, and the patient was counseled that this might be difficult to remove because it seemed embedded in the myometrium. But the patient was in such severe pain that she wanted the team to attempt removal. And doing it under ultrasound guidance was not discussed, which I think should have been discussed, given the extent that this IUD was embedded. And I believe that they didn't talk about future fertility and repercussions of retained pieces, which I definitely think should have been discussed as well.
The standard of care, right, is removal with ultrasound guidance. That we're lucky that she doesn't desire future fertility, because management of retained fragments in somebody who desires fertility, who's symptomatic, is incredibly challenging because it would require excision of the fragments, which is incredibly hard, or just counseling her that she might have complications we just don't know about in future pregnancies.
All right, thank you, Dr. Bayat, and thank you, Viraj, for two really good cases. But we're out of time, so it's time for us to transition over to Grand Rounds. In just a minute, I'm going to ask Dr. Montero to introduce our Grand Round speaker. With regard to attendance, we'll be distributing the CME code via the email system. And for the department attendance, just make sure your name is clearly indicated in the participants list. Dr. Montero, are you ready?
I am. All right, good morning, everybody. It's my pleasure to introduce Dr. Fred Nichols as our Grand Round speaker today for tools of our trade, evolution, and application. Dr. Nichols joined our group in June this year as a hospitalist, and he's had extensive since 2014 experience as a hospitalist. He's worked at several different hospitals. He's been site directors. He's initiated programs. He's continued programs as a hospitalist, laborist, which he's doing now with us in New Brunswick, and will help me do the same in Somerset in the near future. Dr. Nichols attended the New York College of Osteopathic Medicine and did his residency at St. Joseph's Medical Center in Paterson. Like I said, he's presently working as an assistant professor with us as a hospitalist. And I welcome him to, and I'm looking forward to his discussion on tools of our trade. Thanks, Fred.
Where?
Right there.
All right. I'm sorry. Did you hear anything I said? Well, I'm so sorry. I didn't realize I had it on mute button, so I apologize. Well, I appreciate, Tony. Thank you for the introduction, and happy holidays to everyone. I do apologize ahead of time if my slides are not as pretty or as decorated as they can be. I am a little bit old school, so I just provide the information. The art side of my brain never really developed, so it's the information content is there, but all the background pictures that could fluff it up probably aren't as sharp as they could be. But it's a topic that I've always had interest in, from my training, and depending upon the different attendings who are also listening, we all come from obviously different training background and exposures. And I had the pleasure at St. Joe's at the time of training with some very, quote, old school docs, old school ways, in the sense of the use of some instrumentation and techniques that are unfortunately just going by the wayside now as a result of various issues that we'll talk about. It's a lot of information and content. This talk about forceps and vacuum is really a hands-on discussion from a practical standpoint. And at any point in time, if a simulation lab wants to be run by the department, I'd be happy to participate in that for the benefit of our resident staff and any training, that wants to be done, because it's hard to talk about something that really requires a hands-on approach to things. But the tools of our trade, evolution and application. And let me see if I can get this working. I don't have any disclosures at this time. The learning objectives: at the conclusion of this activity, participants should be better able to analyze the historical context and advancement in operative vaginal delivery, to understand its current clinical application, demonstrate the ability to select and apply appropriate instruments for operative vaginal delivery based upon patient-specific clinical scenarios, evaluate the risks and benefits of operative vaginal delivery to improve patient safety and optimize outcomes, and implement evidence-based strategies to reduce complications associated with operative vaginal delivery. So let's look a little bit of the history. How does one come about as far as understanding operative vaginal delivery? You have to put yourself in the times of when, and think about through the era that we're speaking of from a historical perspective. There's very little written about operative vaginal delivery. It started 6th century BC in Hindu medicine. There's some mention of it. It's found in the writings of Hippocrates during Greek and Roman era from 500 BC to 500 AD. Mostly at the time, they were using kitchen tools and utensils to avoid maternal mortality, as labor occurred over several days, often leading to intrapartum death. The mother was always the primary focus. Fetus was not really considered, it was considered secondary at the time. It was always to save the mom. The instruments used to assist in delivery through history, one was called the fillet, which was a loop placed around the occiput for traction. It was either soft, made of cotton, silk, or leather, or could be firm, made of cane, whalebone, or wire. There was also the vectus, otherwise known as a lever, made of bone, ivory, or metal. Similar to a single forceps blade, in which the pubic bone was used as a fulcrum to correct the malposition or assist in descent. So basically, they realized something is stuck. How do we unwedge it? And they used the pubic bone as a fulcrum to basically pry the baby out. Let me see. Destructive instruments, perforating scissors, a crochet sharp hook, blunt traction hook, crushing cephalotribe, or a cranioclast. Rarely was a cesarean section was typically only done, post-mortem. It may have been due to religious edicts at the time or in a very vain attempt to rescue a live infant. Obviously, they weren't going to operate at a time, no anesthesia, operate on a live mom in order to save a baby because the mortality was obviously evident. It's only been in the last 4 centuries that the attitude really has changed to place the importance on the fetus. Before the 17th century, the male attendant, otherwise known as the accoucheur, only was present when called by the midwife for use of destructive instruments to deliver the obstructed fetus. The emphasis of the male accoucheur was to save the mother. The presence of, quote, the doctor meant a bad outcome for the infant and the mother. So basically, midwives did all the delivery aspect, obviously primarily female. There were no male midwives at the time. And the, quote, male doctor or assistant just came in to, unfortunately, take care of the dead fetus, typically. Then in 16th century, William Chamberlain, he was a French Huguenot who fled to England from Catherine de' Medici in France due to the ban on Protestant physicians. Because of him and his 2 sons, Peter the Elder and Peter the Younger, use of forceps to assist in live birth begins. Both the sons are members of the Barber Surgeons Company. They both fell out of favor with the College of Physicians due to inattendance at lectures and the poor dress style of Peter the Younger. I don't know what the dress style was in the 16th century, but to be labeled as a poor dress style must have been pretty, I don't know, socially unacceptable. Peter the Elder was credited with forceps invention. He was a surgeon to Queen Henrietta, wife of King Charles I, and he attended to her miscarriage. Peter the Younger was married twice, first to Jane Middleton, who had had 2 daughters and 11 sons with. Second to Anne Harrison, who he had 5 other children with. So obviously his poor dress style really didn't affect his way with the women. I'll just leave it at that. But his eldest son, Hugh, was one of 3 sons to practice midwifery and continue the use of forceps. By the way, he also had another son named Hugh. I don't know, again, what the name favoritism was, but going along those lines. There was incredible secrecy regarding forceps use, though, at the time. When forceps were to be used by the Chamberlains, they were the only ones present at the delivery. The midwife was not present. The instruments were in a gilded case. The women were blindfolded, and the birth occurred under blankets. They did this, and the family did this for over 100 years of delivering babies or assisting in the delivery with the forceps. Now, mind you, at the time, the forceps did not come apart. They were a single instrument. So using this on the mother in the secrecy under the dark in the blankets, that would have been at a time with, you have to put yourself into perspective. There was obviously the religious influence, there was the royalty influence, there was the secrecy behind this. Nobody knew what was going on. So the fact that they did this for so long, good, bad, and different, it just occurred. Excuse me. The son Hugh in 1670 decided to visit Paris to sell the idea to the French government. He was running out of money. But in France, there was a physician named Francois Morisot who challenged him to deliver a rachitic dwarf who had a deformed pelvis and had been in labor for 8 days. The delivery was unsuccessful, so he did not sell the idea of the forceps. However, Francois Morisot had published a book in French that he then translated into The Accomplished Midwife. Now, because of this translation, and when he brought it back to England, excuse me, in 1673, he became physician in ordinary to King Charles II. And in 1685, was elected a fellow of the Royal Society. The king, though, was forced to abdicate because of political influence at the time, so Hugh was accused of practicing without a license. He fled to Holland. He then did sell some of his instruments to the Dutch obstetrician Van Ruyenhuizen. The original Chamberlain instruments were discovered in 1813 under the floorboards of their house in Essex. They were hidden there by Peter the Younger's wife. They are currently on display in the Royal Society of Physicians in London. But then around the 18th century, forceps started to appear due to one of the flexible models that Van Ruyenhuizen, he had added a lever to. I couldn't get a picture of what that was about, but some sort of extra handle that he placed on it. Then comes along 18th century, some more familiar names. William Smellie, excuse me, the foremost OB at the time. He started to think about the concept of avoiding the loss of children. He invented the English lock, which allowed insertion of a single blade at a time. That's what's still used today. He introduced the pelvic curve. He covered blades in leather and lubricated with hog's lard to ease insertion and prevent venereal transmission. Could not find the study where hog lard were looked at for VD, but again, that's the thought at the time. In 1752, he published his treatise on the theory and practice of midwifery, which established the rules of forceps application at the time. But now you start noticing a change that they're starting to think about the baby as an important entity in the process. However, like everything else, Smellie was met with opposition at the time. Midwives had called him the great horse mother of a he midwife. Again, translation-wise, horse mother, you can take from it what you want, but the midwives felt the encroachment of the male physician into their domain. A fellow OB named William Hunter favored the conservative approach, and he was appointed as physician to Queen Charlotte in 1762. He actually carried a rusty pair of forceps with him to show people that he never had to use them, and it was better to just do the conservative approach. He was actually one of the first obstetricians to enter into normal labor, so I guess to be called a true midwife at the time. The conservative approach got challenged, though, with the death of Princess Charlotte from a postpartum hemorrhage. Labor had occurred at 52 weeks. Gestation, it lasted 50 hours, and it resulted in a stillbirth. Because of the severity of that event, the king was left without an heir, and her obstetrician, Sir Richard Croft, he shot himself in both temples at the same time, by the way. So you can see how the development through history, the implications, but political motivation, political connection, good or bad, and then the outcomes, how it led to the evolvement or the evolving of this discipline and the evolving of the use of the instrument. In the 19th century, Dr. David Davis was the first professor of midwifery in the University of London. He was the obstetrician for the Duchess of Kent. And he was also interested in developing instruments for minimizing trauma to mother and baby. His focus was on the small, deformed pelvises resulting in prolonged labors and disproportion. They started to develop longer forceps based upon the axis of traction, which became popular. So basically, they started to think of the physics behind how the pelvis is shaped and the dynamics of the birth process itself. Before, literally, the forceps, a one-piece instrument, were placed in the vagina and a direct straight pull, not following any pelvic curve, was just performed. The design of Simpson's, Barnes, and Dr. Anderson, who was put together a combination of Simpson and Barnes, as you see in the following picture. Their forceps, the Simpsons to the left, Barnes in the middle, and then Anderson just sort of tweaked that a bit. Finally, in the 20th century, the emphasis was put more on the fetal well-being, improvement in cesarean section risks. High forceps disappeared, meaning head above the pelvic brim. But in 1916, Keelan developed forceps for deep arrest in the mid-pelvis, which were straight with a slight pelvic curve, a sliding lock. He made it very clear and very important. Accurate position and diagnosis was extremely important, and rotate the head first and then apply traction. It was a two-step maneuver. Don't corkscrew the baby out. You reposition into the proper alignment for the pelvis and then deliver the baby. However, his native country of Norway still hadn't accepted his principle for another 16 years until 1932. Excuse me. Shorter forceps also started to be developed for protecting the fetal head. Modified Simpson's, and in 1935, Wrigley's forceps. We'll see some pictures in a second. So we see the Simpsons, Elliott, Keelan's, Piper's, Bailey Williamson, Tucker McLean, Barton, forceps with traction handle. There's not enough time to go into all the structural stuff of the forceps itself and the various applications, because we'd be sitting here talking for days about it, and their application use is getting even more limited depending upon experience and what's in favor of the day. However, attitudes and publicity, or I should say public opinion, still drive a lot of, at the time, medicine and drive attitudes. Around the turn of the century, Joseph DeLee of Chicago began the era of prophylactic forceps. He looked at labor as a pathologic process, the second stage causing damage to maternal soft tissues, and the fetal brain being damaged against the bony pelvis. So we should not allow the woman to labor. We should facilitate the delivery. The solution: ether anesthesia in the second stage of labor, forceps delivery with a wide medial-lateral episiotomy, and manual removal of the placenta. That led to up to 50% forceps rates over a generation of physicians in some hospitals around the country. So a matter of a public importance or following the word of the day wasn't based upon anything else than somebody important coming up with an idea and then people following it. Moving on to the vacuum extractor, has obviously a much shorter history. Oh, I apologize. The first recorded use was in 1705 by James Young, a surgeon in Naval Hospital in Plymouth, England. His device did not work. It was about 100 years later that literature starts showing. About 19th century, Neil Arnott, a Scottish physician in London, outlined the principles of a pneumatic tractor, but never developed it. You can see how, yes, he came up with the idea, thought it was a good idea. Oh, I apologize. But he did write, and quote, "It seems peculiarly adapted to obstetric surgery as a substitute for the steel forceps in the hands of men who are deficient in manual dexterity, whether from inexperience or natural inaptitude." So basically, if you couldn't use the forceps, and yeah, you could probably use the vacuum, but the reason you're using is because you had no skill. So how do you think that was going to be adapted by the folks at the time, in the thought process at the time? In 1849, James Simpson, yes, the same Simpson who developed the forceps, he had developed actually a suction tractor and used it infrequently, but never wrote of it again. 1 year earlier, he had developed the forceps, which obviously were popular and continued to this day. Peter McKay of Philadelphia was the first to point out the importance of flexion of the fetal head during a vacuum-assisted delivery. Again, they did not think about the mechanics or the physics behind it. They just place whatever traction device on and pull directly straight out. In 1953, Tage Malmström of Sweden was responsible for the beginning era of modern vacuum-assisted deliveries. He designed a metal cup with a curved-in margin. It produced a chignon, and I apologize if I'm pronouncing it wrong, which increased the surface area. But basically what that was, think of a old-style hairdo of a bun on the top of the head. Well, basically sucked the skin and the scalp up into the cup, thus producing a larger surface area, but it left a huge deformity on the top of the head. Suction and traction were attached at one port at the top of the cup. At the same time, Geoffrey Bird from Papua New Guinea, he emphasized the need to place the cup over the flexion point of the fetal head. The flexion point is 3 centimeters in front of the posterior fontanelle. And we'll see diagrams in a short time to illustrate that. He also separated the suction and traction ports, which gave greater maneuverability to the apparatus. And he actually indented the top of the cup to bring the traction closer to the fetal scalp, so there wasn't such a large vacuum space. Also established that traction is a two-handed exercise. The thumb of the non-pulling hand firmly sitting on the rim of the cup, and the index finger of that same hand on the side of the cup, measuring descent. So if a vacuum is placed, one hand is doing the pulling, the other hand is maintaining that the suction cup stays attached, and you can feel the descent come down. That became the basis of best practice in vacuum-assisted delivery. Bird's recommendation, the modification of the maelstrom cup, correct placement over the flexion point, and finger and thumb traction technique. In 1973, the soft Celastic cup was developed by Dr. Kobayashi at Tokyo Medical School. It had less superficial scalp trauma. It produced less of a chignon. There was no reduction, though, in the rare intracranial trauma, and had a higher failure to deliver rate compared to metal cups, though, at the time, 25% versus 4%. So yes, it led to maybe less trauma, but it was less successful at the time in accomplishing the delivery. And finally, in the late 1990s, Aldo Vaca, who had worked with Bird back in Papua New Guinea, merged the ideas of Maelstrom and Bird and developed a hard plastic cup with 2 ports. It used a palm compression vacuum pump that was called the Omni Cup, that was quite prevalent and popular throughout developing countries during that time frame. Now, from general information standpoint, the vacuum to forceps ratio currently being used is roughly 4-to-1 around the United States. Why is that? Medical legal implications and fear of litigation. Now the reliance on cesarean section. Perception that the vacuum is easier to use and less risky. And unfortunately, decreased use in training programs. So forceps, which have been obviously around for 300, 400 years, really used in the past century to century and a half, are falling out of use? And is it a lost art that's going to go away? You know, there's still perception, unfortunately, among the general public too, and education is still key. The forceps do not squeeze and pull the baby's head out. They are help to guide the baby's head down. The idea of the suction of the vacuum seems less traumatic, even though issues can occur with that. But again, it's a tool like anything else, and proper education of our patients is always key to help to make them aware of the possibility of what may happen during the course of assistance in their delivery. The forceps designs, just in very general terms, Simpson or Elliott's are for outlet deliveries with molding. The Keelan or Tucker McLean's rotational deliveries, no molding. The Piper forceps for after coming head and vaginal breech deliveries, which we know vaginal breech deliveries are in the decline, obviously, with the improvement in cesarean section, whether it's improvement, obviously, in operative risk, or is it increase in cesarean section due to medical legal potential implications? Again, a question for discussion, but not a definite answer that I can give at this time. The shape of the forceps, there's a right and a left blade. Blades are talked about in relation to the patient, not in the way you're holding it. The blade consists of the pelvic curve, the cephalic curve, shank, the lock, the finger guard, and the handle. And yes, if you haven't held them in a while or played with the various ones, these can be large instruments. If you have I had a colleague of mine who had a very small hand, and she said she can't hold the instrument well. She didn't feel comfortable with it. So again, it's a tool that you have to see, is it adapted for the individual? It's not for everyone, I get it, but you have to be comfortable with your tool and be skilled in the tool that you're willing to use. You also have to know the tools that are available at your particular facility for the residents, wherever you go to train. And we'll speak of that in just a moment. The various, it extends a little bit wider than just what the discussion is about here today, about implications, indications, risks, and everything else. You have to always take into account the whole scenario that you may be applying the use of these instruments in. I'm sorry, one moment. Indications. First and foremost, cesarean is always an option. Well, it may be at your particular institution where you're practicing at. If you're in a third world or undeveloped country or with limited resources, it may not be the option of choice. You should have a non-reassuring fetal heart rate pattern. Now, again, does it have to be there? No, but it may be an indication where you're going to use it. Shortening of the second stage of labor for maternal reasons, maternal fatigue, cardiac issues, respiratory issues, physical issues, patient unable to assist in the delivery or in the pushing. Prolonged second stage, not due to dystocia. In the nulliparous, that would be no anesthesia for 2 hours, regional anesthesia for 3 hours. In the multiparous, no anesthesia for 1 hour, regional anesthesia for 2 hours. And in use of the delivery of the after coming head in a breech presentation. Conditions that must be present: complete cervical dilatation, ruptured membranes, fetal head engaged with a known fetal head position. Now, I know it sounds silly, but known fetal head position, what I find is a difficulty in the laborists and working the past in the various facilities is, you know, you come on shift and you'll come on and examine a person who's 8 centimeters, and you're getting them when there's severe molding, swelling. Sure, could you be mistaken? You can't feel the fontanelle easily because you haven't tracked it through the whole course of the labor process. Might be a little bit challenging from that standpoint. They have to have an empty bladder. So if they did not have a Foley, then place a red rubber catheter to drain the bladder. There should be no evidence of cephalopelvic disproportion. I don't know what that really means when they say that as a statement, because you don't prove cephalopelvic disproportion unless you really know, estimate fetal weight. At the time, I know we used to do pelvimetry to determine it, and I know there are various studies that are looking at looking back at that, they used to send patients for x-rays at the beginning of my residency. They were doing that, trying to do x-rays of the pelvis to determine size and shape, and they were notoriously inaccurate. So again, there's not a standardized, definitive method as far as that's concerned. Adequate analgesia, patient has to be comfortable. Cesarean section capability. So yes, the team should be available in case you're unable to accomplish your task. And of course, an experienced operator. How do you get experience? You know, there's that delicate balance now where in training programs years ago, they used to apply forceps to assist in delivery that probably did not need forceps, but that was for the training purpose. Nowadays, that would be frowned upon. Who's going to put forceps on to deliver a baby in a multiparous individual that easily can push the baby out? That's looked upon negatively. But when it comes time for the training aspect of getting it applied correctly and utilized in the emergent situation, usually want to do it in a controlled situation first. So a sim lab can help in that regard, but again, it is only a simulation. The biggest one that I feel is important is the patient consent. You know, lack of information, lack of education is key to this whole thing, and perception by the patient. In the laborist role, I come in, I have never met the patient. I don't know how they've been counseled. I don't know who counseled them. I don't know if they've been talked about to in their native language. And then all of a sudden, in the last 3 minutes, I have to quote, explain to them that you may use with forceps. We're going to use a tool, They have either preconceived notion or whatnot. In my private practice, which I had maintained up until becoming the laborist, I had provided an information booklet or information sheet at the first prenatal visit, which yes, basically was a summary of vaginal delivery, cesarean section. Then I had a forceps/instrument page, and it was just for information, but also discussion. And at least it got the idea out there first. Then at the second prenatal visit, I would address any concerns they had and talk to my patient about what this is about, because there is a lot of misinformation, as we're all aware of. And that leads to then, unfortunately, the medical legal implication. I happen to do case reviews also for attorneys. In one forceps case, the patient says, they put salad tongs on my baby's head and tried to yank it out of me. That was it. They were given no explanation. And granted, everything was done correctly from a medical perspective, but there was no information. There was no proper consent. And that was what the case all hinged on, was I did not give consent to that to be done because they could have done a C-section. And that's unfortunately the type of information that is out there that then causes some physicians obviously to stop using this technique. And some hospitals don't even have forceps present to be used. Outlet forceps classification. Fetal scalp is visible at the introitus without separating the labia. The fetal skull has reached the pelvic floor. The sagittal suture is in the AP, right or left OA or OP position. The rotation of the fetal head is less than 45 degrees. So again, knowing the position is key. By the outlet, you can see portion of the baby's head. Low forceps, leading point of fetal skull is at +2 or greater and not on the pelvic floor. There's 2 subdivisions, rotation less than 45 degrees, rotation greater than 45 degrees. Mid forceps, head is engaged, but leading point of fetal skull is above the +2 station. Under no circumstances should forceps be applied to an unengaged head. Now, I know it sounds silly to have to put it in writing, but that's how forceps used to be applied, to just, quote, pull the baby down. Preparation of the patient is key, knowing the position of the fetal head, the station of the fetal head, adequacy of pelvic diameters. How to apply the forceps. Before application of the forceps, and you've done your exam, you ought to do a phantom application externally. So you know how they're going to sit, how the handles are going to look. So it's a visual representation of after the forceps are applied, of how they should be present and resting in your hand. The goal is to fit the head symmetrically and evenly. After application, they should articulate easily, meaning the two single blades should easily come together. If you see someone forcing the blades or having to twist and turn to get the blades together, that is not a proper application and it should be abandoned. If not, you remove it and you try to reapply. If it articulates easily, the sagittal suture should be perpendicular to the plane of the shanks of the forceps. The posterior fontanelle should be 1 finger breadth away from the shanks and equidistant from the side of blades and in front of the articulated forceps. If you have fenestrated blades, no more than 1 fingertip should be admitted between the fenestration and the fetal head. So basically, you're putting the blades on the baby's head. The blades should fit snugly. If they are too loose, the head is too small, the blades are too big, your instrument is too big. And when you start pulling, you're going to cause more damage because you're not snugly grasping the baby's head and guiding it down. You're just basically pulling on whatever part catches on the blades. So visual representation, left blade is always placed first. The handle is put directly straight up. Fingers are inserted in the vagina and the blade is passed along your fingers, along the baby's head, slide up and into the pelvis. When that blade comes positioned properly, as you see, it drops down into position on the side of the baby's head. The right blade is then inserted. Again, so you have to be ambidextrous, being able to examine with both hands and insert, the tool or the instrument in order to be able to feel what's going on. And then in position, you see how it articulates easily and how the baby's head is cradled between the blades of the forceps properly. With the patient pushing, as you guide the baby's head down, you'll see it's a 2-step process. You're following the sacral curve down and out. So one hand is providing traction, the other hand is providing a downward motion to get under the pubic bone. So traction should be applied in a plane of least resistance and should follow the pelvic curve. Downward pressure on the shanks, outward pressure on the handle. As fetal head emerges, disarticulate the forceps and allow the fetal head to deliver via modified Röntgen maneuver. You do not pull the forceps out, or I should say, you do not pull the head out with the forceps still attached. You get it down to the point where it can deliver spontaneously at that point. And after delivery, you have to examine and repair in the customary fashion. Episiotomy should not be routine. Dangers of the forceps. For maternal, you have lacerations, cervical, vaginal, rectal. Pelvic hematomas, urethral bladder injuries, uterine rupture, that's a rare one, but it can occur. Blood loss with transfusion. Fetal injuries, facial laceration, forceps marks, facial brachial plexus palsies, cephalohematomas, skull fractures, intracranial hemorrhage, seizures. Now to talk about the vacuum extractor. Indications and prerequisites. Basically the same as the forceps, except obviously there's no application for the aftercoming head in a breech presentation. Various devices that have come about, basically you have the suction cup, tubing or connection to the vacuum pump. That was the Mighty Vac. Other instruments that are still around or present. The contraindications to vacuum delivery: face presentation, breech presentation, true cephalopelvic disproportion, congenital anomalies of the fetal head, such as hydrocephalus, gestational age less than 34 weeks, an unengaged fetal head, fetal demineralization disorder, such as osteogenesis imperfecta, any bleeding abnormality known. Again, how are you going to know some bleeding abnormalities or not? But if suspected, such as hemophilia, or estimated fetal weight greater than 4,000 grams. The vacuum application should be tested prior to use on the patient. You insert the vacuum cup, directing pressure posteriorly. You want to remember the head is sort of coming down on an angle, so you just don't want to go straight in. You have to follow the curve of the sacrum, curve of the vagina, and posteriorly want to make sure that you get good attachment of the cup. The center of the cup should be over the sagittal suture, 3 centimeters anterior to the posterior fontanelle. Space should be available to allow for maintenance of the flexion head during the entire procedure. So you have your posterior fontanelle. The cup should fit, again, the center of the cup, 3 centimeters in front of the posterior fontanelle. You always want to check before doing any traction. There's no maternal tissue under the cup margin. Is the cervix clear? Is the vaginal wall free? Cup is placed obviously midline, not off center. While holding onto the cup, you apply some suction, 100 to 150 millimeters, and you recheck the above to make sure good proper placement, no tissue, so you really have to feel the whole perimeter of the cup. If it's okay and everything placement looks fine, you increase to 500 to 600 millimeters at the beginning of the contraction, and as the mother pushes, apply traction downward along the pelvic axis. Decrease pressure between contractions if more than one attempt is necessary. As the head emerges, the axis of the traction is extended upward to a 45-degree angle from the floor. So just as in the forceps, you bring the head down and up, same idea with the vacuum. But with the vacuum, only after the head has completely delivered should suction be removed. So do not release suction while the head is just on the perineum. However, vacuums, unfortunately, were thrown a curveball back in the end of the 90s. In 1998, FDA issued a public advisory statement regarding fetal complications associated with vacuum delivery. Recommended only for use for specific indications, but they didn't really relate what that was. You have to have experienced personnel. You have to understand the particular instrument at your institution. Again, whichever hospital you may be going to, what vendor they use, are you well adept at using it and using that instrument, and do all your staff know how to use that instrument? Neonatal team trained in complications. Neonatal team made aware of vacuum use at the time of use, and report all adverse reactions to the FDA. Now, the term neonatal team, again, you have to then think about what does that really mean? If you're in a wonderful university setting, as we are, where everybody under the sun is available to help you, yes, you have the resources available. If you're in the middle of the Missouri at a small community hospital, your neonatal team is probably the same labor and delivery nurse who's just taking care of the baby. So do you have a neonatal team present? Do you have someone experienced to handle complications or not? That may preclude you from wanting to even attempting the vacuum. Don't forget, it's not just delivering of the baby, it's caring of the baby afterwards in case there is a complication for both forceps and vacuum. So that's where we were talking about earlier, taking into account the entire scenario of what works best for you and what works best in the situation that you're in. Vacuum injuries, the most common is retinal hemorrhage up to 50% of the time, but they usually don't have any much significance associated with that, fortunately. A cephalohematoma is blood collection beneath the periosteum, which tends to be contained and would resolve typically spontaneously. However, a subgaleal hematoma is above the periosteum, and this could be quite significant. It occurs in about 50 out of every 10,000 vacuum deliveries. The subgaleal space actually goes from the orbits of the eyes to the nape of the neck, and that space can accommodate up to half of the blood volume of the baby. So without proper recognition, severe injury and or life-threatening complication can occur if it's not recognized and identified. Also, intracranial hemorrhage can occur as a result of the vacuum injury. I don't know, it says intracranial hemorrhage for both the forceps and the vacuum. I don't know, is that a direct result of the instrumentation itself? Were they good candidates to begin with? Was it excessive pulling? Was it too much force? I mean, obviously there's so many factors that go into this at the time that you can't record or know, but this is a listed complication. To reduce the injury when using a vacuum, apply traction only with maternal pushing. Do not try to rotate the head via torsion and twisting. This is not a corkscrew. Again, with the forceps, you may be able to rotate a little bit and pull at the same time because you're guiding the whole head as a unit. With the vacuum, you're just basically attached to the top of the skin at the top of the head. So you start twisting. The only thing you're doing is you're twisting the skin at the top of the head. You're not going to affect any change on the baby's skull. Total cup application time should not exceed 20 minutes. An absolute stop if the cup pops off twice. Do not apply a third time. Do not apply a third time. Simple. And you also want to stop if there's no fetal descent with the first pull. If it's not moving on the first pull, it is not going to move on the second, third, fourth, fifth, sixth, whatever time. Again, if it's not moving, it's not moving. Neonatal staff should be present. And I know it sounds pretty simplistic, but do not switch to forceps. Oh, I'll try vacuum first, and then I'll go to forceps. They're both tools to be used in the same indications. One is not a default measure for the other. The fact that this has to be written about means that obviously people were using it as such. My references for the various historical aspects, obviously I didn't search all the Old English texts, but some good references out there. Any questions?
Thank you, Dr. Nichols. Thank you for that excellent review. Are there any questions? I see that Dr. Rosen has his hand up.
Hey, Fred, thanks so much for giving us a really interesting talk. And I don't know why I always love hearing about the history of the forceps. It's so weird that they kept the forceps secret for a century and really weren't benefiting anybody but themselves. Or they were benefiting women too, sort of, but they profit first. This is my question. So I trained 20 plus years ago at a center that had the highest forceps rate in the country. It was 40%. 40% of our births were by C-section, 40% were spontaneous vaginal births, and about 20% by C-sections. But watching those cases, I got to see a lot of pretty terrible outcomes, including like avulsion of a fetal head, not trying to scare anybody, and some other like pretty gruesome outcomes. Do you think that women and their babies are safe? Like, while it's clear that some women will benefit from forceps, and I still do them here, do you think overall that women and their babies are safer now that we've cut down the use of forceps, or do you think that the lack of training with our residents and trainees with forceps is hurting our patients? Let me say it that way.
It's an excellent question. I've been doing this almost 30 years now. I use forceps probably about 10 times a year, and knock on wood, it's been at indications typically where the C-section can't be accomplished quickly, and it is more of an emergent need because the rate of time to be able to get to facilitate a cesarean delivery. Now, my personal feel is I always like to have every tool at my exposure because unfortunately what I've found in medicine, this is my personal take on it, they make these universal adapted rules. Forceps this, vacuum this, cesarean section this. Instead of, well, no, it's a variable. We live in a very variable, ever-changing environment at the time. The assessment of the patient, what clinically I feel, I don't put forceps on unless I feel I can easily get it done. And I'm not cavalier. We've all met those docs from those, years gone by that are, oh, we can do everything with forceps. We can do everything with this. And those are unfortunately the ones that have led to the statistical error. I think cesarean section has made it easier, especially with, unfortunately, increased birth weights of babies, increased maternal weight, because obviously when you have the number of heavier patients that I've personally been seeing now, well, there's less vaginal space. There's less room. Sometimes less ability of mom to participate from a physical ability to push. So there's so many of those variables that get thrown into it. It's a tool that, you're right. How do you get experienced personnel? If you do, I even argue to say, am I experienced because I do maybe 10 a year? I don't know. I'm more experienced than somebody that does none. But what is that value? What is that magical number? I think it's a tool that, depending upon where you're at, if you're going to be trading, if you're on in a underserved area, lack of resources, I think having the tools available and knowing how to use them to help facilitate the delivery if needed are important. If you're out on an Indian reservation, if you're out somewhere where there's not in-house anesthesia, not readily available personnel, which still exists obviously in hospitals around the country and around the world, yeah, having those tools available are probably important and positive. In an institution like ours, where the teams are readily available and everything's available down the hall, the tools aren't going to be used as often. So I don't know if that helps the question there, Todd, but that's my take on it.
Thanks.
Sure.
I see that Dr. Patrick has her hand up.
Good morning, and thank you for your talk, Dr. Nichols. I also always enjoy sort of hearing historical perspectives on things. I guess I have a sort of a question and a comment, and it goes back to, informed consent for these procedures. So where I did my residency training, we actually had a blanket delivery consent that we used on every single patient admitted for delivery, which included uncomplicated vaginal delivery, SVD, operative vaginal delivery, and C-section. And we went over the risks and benefits of all of those things on admission. Obviously, someone coming in for a scheduled induction who's totally comfortable, that conversation is going to look and sound a little bit different than someone who's 9 centimeters and about to push. But I always found that to be a helpful conversation, and it was exceedingly rare that we had a patient, decline an operative vaginal delivery, which was an option on that form. So I'm curious, as someone who's been a laborist, if you've seen other institutions do something similar, and whether or not we should think about doing something like that in our system.
I believe information is always key and education is key. We all know now as things have as things have improved or become easier with electronic signatures of stuff. Here is your consent form, sign it. Well, is it in their native language? Well, 9 times out of 10 with our Hispanic clientele, it may be, it may not be, and they just sign it. Everybody just sign it. Nobody reads it. And so how much time is really taken? You're right. What's the magical answer? If the consent can be done a month at 36 weeks, here's information, read about it, sign off on it at this time. And maybe, I don't know, is that a pre-consent? I think the consent procedure is only done in the hospital setting because of a time constraint. I don't know if that's a state law, if that's a rule or whatever else, because there's always these time frames of 30 days. Every hospital, and what's also funny about that is all the hospitals I've been on staff at, everybody's got a different consent form. I don't get it. I sit back and I go, we're doing the same thing in every place. How come? Well, our consent form was vetted by our attorneys. Okay, well, the hospital attorney is somewhere else. They come up with a different consent form. One is 2 pages long, one is 6 pages long. And nobody, you and I both know, nobody's going to sit there and read 6 pages of stuff when they're in labor. We can go over it verbally, but what do they hear? How much do they hear? Information ahead of time. I don't know if we present that ahead of time, say at 36 weeks, they're given a pamphlet. It doesn't have to be necessarily by the physician, obviously, ideally by the physician, but any committee can provide the information. And then physician is there to address the questions at that time in a non-emergent way. That would probably be ideal, but would that be accepted by the hospital legal world? You and I both know that so many legal things come about as a result of typically a bad outcome. Oh, that happened. Oh, so we have to change the whole process now. as opposed to forethought. Well, this is a little forethought in that regard, that you're right. But if we, in the hospital itself, if 2 forceps are done out of, 4,000 deliveries a year, then people are like, well, we're spending time talking about something that's very rarely done. Yeah, but still, it should be. So there's inconsistency across the board, basically, unfortunately.
I see that Dr. Silverberg has his hand up.
Thanks so much for that really good talk. One comment is, as obstetricians, I feel as if we are losing some valuable skills. One of the things that I always try to emphasize to the residents is I ask, what is the shape of and the size of the pelvis that we're dealing with? What's the position of the baby's head? I mean, these things are very, very important because there are things that we can do. We could rotate the baby's head to a much better position. And then we can assist the patient by helping her turn and moving that head down. And these are skills that are extremely important, and we're not doing it as much as we used to. And as far as forceps versus vacuum, forceps I believe are a much better traction instrument. Vacuums are really not for traction because they'll pop off and cause greater injury. So if you're really very skilled at some of these things, it's more of a tool. The more tools you have in your toolbox, the better. And so that's the whole object here, is to get more tools so that we can assist the patient better in that particular situation.
Thank you.
I see that Dr. Sharma has her hand up.
Thank you, Dr. Nichols, for this talk. I loved the history of it. It's a great refresher. So I kind of agree with everyone here that the more tools we have in our armamentarium, we can utilize it when it's needed. And 100% agree with Dr. Silverberg here that, the pelvimetry, assessing the baby's position, all these things are extremely important. And as an obstetrician, they're almost, I feel that imperatively you should be knowing these things. But with the dwindling number of providers, and I see the hunger in the trainees. I do know that they want to learn. So do you have any thoughts like what should we do? I don't know how many forceps or operative delivery skilled providers here we have, probably not many, but then what can we do? What are the things we can utilize to help our trainees?
One idea, I don't know how it would be accepted or passed or what has to be done, since I'm new to the academic world here, so how things get put into play. But if we said, even for patients with routine labor, just like there's a number of studies that are done for different devices as patients come through the clinic or through the office setting here, to sit back, that would just do just for application of the forceps, for example, or application of the vacuum, whatever device may be more comfortable in the residents' or hands. That's for application, for assistance. So even in quote, non-clinically indicated cases, would that be allowed? Would that be looked upon negatively? Because that's the only way it's really going to get it done. I mean, you could have 10 women come in about to push out their 5th baby, putting the forceps on just to help guide it down as they're pushing, just to get the feel of what it's about. That would be tremendous. Is that allowable? Is that something that I help carry the ball with that? I have no problem doing it. I'm sure Dr. Silverberg would assist me, since it's going to be the 2 Freds in the department that I think are the forceps guys. So just to throw that out there, okay, which is wonderful. But would that be allowed? I don't know.
Yeah, good thought. We do have a couple forceps trained providers in the MFM practice. I can tell you that.
Okay, good.
Yeah, I think Dr. Rosen, Dr. Kinfinski, myself, and
Wonderful. Sorry.
Yeah.
Yep.
No problem.
Don't know everybody's historical skill set, but again, at the end of the day, is that something that's going to be accepted and allowed, or want to be done? Because just to rely upon it in an emergent situation, that's not the time to be sitting there chatting, here, try this, try that, do this, do that. when time is of the essence, so to speak. That's what makes it a little difficult at that point. And a sim lab is just that. It's a sim lab. It helps, but real life is always better.
All right. Well, thank you so much, Dr. Nichols.
Thank you.
And we're just about out of time, so we're going to call it here. And I hope everyone has a safe and successful day. Thank you.